Hi, I'm Dr. Rachel Tate, coming to you with Dr. Nina Narasimhalu from RWCS 2019 in Maui. And Nina has an amazing presentation about her poster, which, the fellows are supposed to bring us a poster that will be really engaging and stimulating, and that's exactly what she's done. So I'm sure that Irvine is very proud of you. But Nina, tell me what brings you here. Tell me about your poster.
Sure. Thank you so much for having me. It's been a blast so far. I have a 33-year-old gentleman who presented with bilateral lower extremity swelling, myalgias, generalized weakness, along with progressive shortness of breath that had been going on for about a couple of weeks. He had actually been hospitalized at another hospital and left AMA, ended up coming over to our emergency room for further evaluation. From our history, we learned that he actually was an active IV drug user, using both methamphetamine and heroin, and his last use was 1 day prior to coming into the hospital. On physical exam, his vitals were notable for some tachycardia. He was also tachypnic. He was saturating okay on room air. On exam, we noticed that he also had this violaceous palpable purpura that you can see on the image here, and he had macules as well that were in a retiform pattern. His labs on admission were notable for anemia and thrombocytopenia, and he also did have some mildly elevated transaminitis and a urinalysis with some mild proteinuria. In terms of his imaging that they had obtained in the emergency room, this was all within the span of like a few hours. They got an echocardiogram that showed that he had evidence of impending cardiac tamponade. Shortly thereafter, he actually was taken by cardiology, had a pericardiocentesis, had a drain placed because they were immediately able to drain a liter of fluid, and then they drained in subsequent days, I think, at least another liter more. Throughout this time, he was having some intermittent fevers, and given his history of infectious or IV drug use and then the rash, we were concerned about an infectious endocarditis, some possible infection that was contributing to his current presentation. But as the workup kept coming back negative, then the question was posed, is this potentially an autoimmune process? We started sending off our labs, and his ANA, double-stranded DNA, along with the histone came back positive. He had some hypocomplementemia, and then interestingly, a positive P-ANCA with both MPO and PR3, which we can see in cocaine and levamisole-induced vasculitis. His antiphospholipid antibodies were also elevated as well. So at this point, when we saw these labs, and in order to further work up the urinalysis, which showed 100 protein, we actually got a 24-hour urine, which showed 1.8 grams of proteinuria. And so we wanted to get a renal biopsy to determine if this was lupus or an ANCA vasculitis presentation. At this point, the patient admitted to cocaine use, but his last use was actually several months ago, so it seemed that the methamphetamine and heroin was more at the more relevant drug use at the time. We ended up getting a renal biopsy, and we discharged him home on prednisone. He unfortunately had a lot of hospitalizations after that initial hospitalization. He really didn't come to any of his follow-up appointments. One of his hospitalizations, we saw that he had constrictive pericarditis. He had renal insufficiency. We gave him steroids again. We started him on Plaquenil and Cellcept, but there were issues of medication adherence. And then he also had multiple PEs, and we started him on anticoagulation. And so this led us to further work up what was going on, because he had all these positive antibodies, but we know that levamisole could definitely cause the positive P-ANCA and the MPO and PR3, but could it also be responsible for some of the other labs? And so from preparing for the presentation and learning more about the case, I saw that with levamisole you can definitely have a positive ANA, a positive double-stranded DNA, positive ANCA with both MPO and PR3, and you can also have a positive lupus anticoagulant, many of the labs which he did have. And so some of the key points to take away from the presentation was that more recently, although we associate levamisole with cocaine, it's now being found in heroin. So in patients that are using really any types of IV drugs, it might be worth to send off for a levamisole level, making sure you check a UTOX. You can always check an anti-elastase antibody, which is both sensitive and specific for levamisole-induced vasculitis. But because of our findings, we really do feel that this patient has a drug-induced lupus, antiphospholipid syndrome, and ANCA-associated vasculitis.
Nina, thank you so much. I think this is a really good case because it really does show us that it's important to talk to your patient. we need to know that they're being honest with us, especially when they come into the hospital. Do you find that the anti-elastase antibody is something that is easily drawn in a community setting? I think it is. And I think that that's something we can all look forward to. So anytime you have an atypical presentation of something with multiple antibodies, it's always important to ask about drug use. Thank you so much. I really appreciate it. And I did not know that levamisole was a cutting agent for heroin. So I learned something, well, in addition to everything that you just taught me. Thank you so much for being here. We've really enjoyed it. And that's all from RWCS 2019 for right now. Check us out on rheumnow.com.